to get things started for our next session here, we're really excited to have Dr. Adesola Odunayo from University of Florida here to talk with us about a variety of different emergency and critical care topics. I'm really excited to see what she's got in store for us. So Dr. Odunayo is the Michael Scher Distinguished Professor of Emergency and Critical Care at the University of Florida. She attended vet school at Oklahoma State University and completed a rotating internship at Hollywood Animal Hospital in Hollywood, Florida. She then completed an emergency and critical care internship at the Animal Emergency Center in Glendale, Wisconsin, and a residency in emergency and critical care at the University of Missouri. And I know we're here in K-State land, so we'll try not to hold that against her too much. But her clinical interests are diverse, but the absolute favorite part of her job is being by her patient's bedside. She also enjoys research studies that answer practical clinical questions and has a focus in acid suppression and venous access. And outside of work, she is drawn to culinary adventures and traveling the world. And so with that, I'll hand it over to you, Dr. Odunayo.
Thank you, Dr. Hall. Can you all hear me? Awesome. Thank you very much to Hills in Kansas State for having me here today. And thanks to everybody for getting up so early on what I consider to be a really cold day. I had a reality check this morning when I stepped out of my hotel room in my sweatshirt. I quickly decided that was probably not the right decision to make. But it also brought back really warm memories of being in Missouri and Wisconsin, where I got to experience the winter. So good memories. I would say over the next 2 hours after lunch, I'm going to step a little bit away from nutrition, but not very far away, because I think everything I'm going to talk about today in combination with nutrition certainly allows us to provide the best care for our patients. So a little bit different, but not so much. I also like to say that I tend to talk too much. So if I don't get through everything, I know you all have my notes. I'm pretty strategic about how I have these. I put the most important things up front. So not finishing does not necessarily mean, it means you all have gotten the good stuff, and I just sometimes get carried away with my stories. All right, so the outline of today is we are going to talk about the most impactful interventions we can make as veterinary professions. I picked a handful of common emergencies, but in the beginning, we're going to just focus on how to approach that patient that comes in on an emergency basis. And as we all know, they may not necessarily scream emergency. It might be a patient who comes in for a well-pet appointment, but this patient has a life-threatening emergency that the owner may not identify or may not realize that it's a big deal. So kind of like I referred to, we see a lot of life-threatening emergencies, and in some cases, the prognosis is grave. Regardless of what we do, that pet is not going to recover. But in some cases, what we do may directly affect the outcome, which we all do a good job of trying to help those patients and stabilize them. So my goal today is to help us identify early interventions we can make. So what things can we do within, again, this talk is titled The First 5 Minutes, but realistically, within 5 or 10 minutes of that animal walking into your practice, what interventions can we make that would directly lead to a positive outcome for that patient? In the interest of time, we're not going to be able to go through the entire management of the case. Again, I just kind of picked a handful of emergency scenarios, but we're not going to be able to cover all of them. I think for the first 20 minutes, I'm going to focus on the ABC. So this is the heart of emergency medicine. And I think this concept is important for every patient, even for those dogs and cats who come in for like vaccine appointments, because we're able to not only like train our technical staff so that we can identify those animals that are dying faster, but also we're ensuring that every patient that we see is stable enough to wait. So for those of you who do ER, certainly you're very familiar. And I think even if you don't, sometimes the wait time is really long. Can this pet wait for like 2 hours before it's seen? The way we make that determination is to do our ABCs, which I also call the triage exam. So this is a quick exam we perform to identify life-threatening emergencies. Technically, this triage exam can be performed in less than a minute. You can do it really quickly. It doesn't take a lot of time to identify what patients you need to drop everything you're doing to try to get to them and stabilize them. And it composes of 3 main things. So the airway, where we want to listen for airway obstruction. breathing, where we want to evaluate for respiratory difficulty, and then finally circulation, which is assessing how much oxygen that patient is getting. And we're going to walk through how we're going to be able to do all of this really quickly in less than a minute. So for airway, when we talk about the airway, we pretty much focused on the upper airway. So anything from the nose oral cavity all the way down to the main stem bronchi. So that's going to be our focus. And the reason this can be life-threatening is usually because there is an obstruction. So there is something that's inhibiting that animal's ability to get oxygen and get rid of CO2. This is probably the easiest part of doing your triage exam because it's characterized by stridor. So you can hear that animal and it is always going to be an inspiration. So you don't have to open the animal's mouth. You don't really have to do anything special. You just want to stand across the table and say, can I hear this dog or cat breathe every time they take a breath? So it's, again, that audible noise you can hear without your stethoscope on inspiration. It's going to be really classic for an upper airway obstruction. Certainly helpful in an animal that's distressed, because I know quickly we're going to talk about interventions and how to stabilize them. But I think sometimes too, you may have had cases where this dog has come in probably 6 times for respiratory distress. You've taken a bunch of x-rays, you don't really see anything, but that animal has stridor. It's just kind of localizing and telling you that you need to do an upper airway exam and look in the upper airway, because maybe that animal has a mass in its larynx or something that you may not be able to see on radiographs. These are going to be the most common reasons we will see an airway obstruction. So this disease processes are very familiar to many of you: neoplasia, laryngeal paralysis, tracheal foreign body. Every time a kitty cat takes a breath in, you can hear it. Kitty cat unfortunately ended up having like a tracheal mass. So again, I don't really need to put my stethoscope on this cat to be able to say that this is an upper airway obstruction. All right, this puppy dog, I would say there's a lot of like talking in the background, but again, every time, other than the fact that this puppy is cyanotic, you can see that every time you take the breath. Any guesses for what the stroke he has? Tracheal collapse, excellent. So we can identify that. And again, not every single animal with an airway obstruction needs emergent intervention, because sometimes they just have that stridor, but they feel proper in their, pink, and they're comfortable. But once you identify that this animal is in distress and this animal has an airway obstruction, what steps can I take to stabilize that dog or cat? So really easy. We're going to provide oxygen in the best way we can. Ideally, I would say it's helpful to have at least flow by so you can walk on the animal concurrently. But if you don't have that set up, sometimes just putting them in an oxygen cage, especially cats, and giving them time to relax is sufficient. I like to get IV access as quickly as possible. I love it because I can give my drugs for sedation, which we'll talk about next. Those are going to be way more effective giving them IV than if you had to give them sub-Q or IM. But the other reason will be if I needed to take control of this animal's airway, so this animal's decompensating, I need to intubate this dog, I already have IV access and it's going to be easier for me to do. So as long as it doesn't stress the dog or cat out, I like to get an IV catheter in, and then we're going to provide sedation. I find this to be very helpful in animals with airway obstruction, especially dogs. And in some instances, I have many cases of dogs with brachycephalic airway syndrome that come in distress. In some cases, that's really all you need to stabilize them. You place an IV catheter, you give them a little bit of TORB, sometimes butophonol and ACE, and then they kind of calm down and they relax. Sometimes they need more, but I think animals with airway obstruction tend to be very responsive to sedation. Dogs, we know that they depend on their airway for heat exchange, so sometimes they get really hot. We want to provide active cooling if their temperature is usually above 105. And then if the patient is decompensating, and I have this last on my list of things to do, but sometimes it's the first thing you do. So you see this animal, it's really cyanotic, and the first thing that crosses your mind is this dog's dying. When you just feel like this animal is going to die, if I don't do something, then we need to get control of the airway. The reason this animal is distressed is because it has an obstruction. So if we can bypass the obstruction with an endotracheal tube or to do an emergency tracheostomy, we have a good chance of stabilizing. What we usually see with animals with airway obstruction is once you intubate them, they get pink, they relax. Many times it's, you may not even need a lot of drugs to keep them under because they can breathe easier. And we can see this is the same Yorkie. He is pink. He is not as distressed as he was originally once he got intubated. The reason he is panting is because his temperature was about 107. So we also had a fan going on him, but he got really hot. Really quickly, I wanted to talk about this temporary palatopexy in animals with brachycephalic airway syndrome. So absolutely, they come in, they look really bad. We can do all those steps, we can get them intubated. The problem is, how do you extubate them? Because if the subpalate is really long, it's an English bulldog, you need to send them 2 hours away to go have surgery or whatever. Sometimes it's challenging to get them where they need to go because they have a tube in. This is a procedure that I have done a handful of, and I am impressed by it. I love it because I can get those dogs extubated really quickly. And what it is, and I would say I have a lot of disclaimers. The first one is I am not a surgeon. I'm actually really terrible at it. So I feel like if I can do this, anybody can. So this is just a dog. I guess my pointer isn't really showing, but this is a dog with the long subpalate. And what you do is just exactly how it's done in that picture. You just place 2 sutures, and they're designed to be temporary. So usually it's going to be absorbable suture. The goal is not to fix that animal, but to get it out of its crisis and hopefully send it over to a surgeon. So 2 sutures, and that kind of attacks the subpalate. It takes it away from the airways so that animal can breathe easier. In all the cases I've done it, as soon as this was done, the animal was able to be extubated and looked much better. Obviously, if there's other things going on, like if the animal has laryngeal collapse, in addition to a lung subpalate, this may not necessarily fix it. But I find this to be really helpful in animals with brachycephalic airway syndrome with a lung subpalate. If you all just Google temporary palatopexy, this paper is going to come up. And while you can't read the paper, unless you have a subscription to it, you can actually watch the video. It's a really nice video where they go through the steps of doing it. So it's something that can be done very practically out in practice. Also, really quickly, just wanted to show if you had to do a tracheostomy because the animal had a huge mass, or in some cases, a bone or a toy, and you could not intubate the patient. If you don't have the Shelley tracheostomy tubes, it's really easy to fashion an endotracheal tube to utilize as a trach tube. So you're just going to cut that endotracheal tube along the length. If you want to utilize, we would only utilize the balloon if the animal needed to be on a ventilator or going to surgery. But if you wanted to utilize the pilot, the balloon, you just ensure that you don't cut along the line. So you're going to cut along the perpendicular surface. And you just make your incision and you reinsert that white little adapter at the end. And then usually I would just use like a 20 or an 18 gauge needle to make a hole on the flaps and attach my umbilical tape so you can tie it behind the animal's neck. All right, so that's all for breathing. I think the airway, the big take home is you can identify usually within about 10 seconds that this animal is in distress. This animal has stridor, and inspiration. This animal has an airway obstruction. All right, breathing is also really easy to identify because the animal is going to come in tachypnic. I'm also really bad with technology. All right, animal's going to come in tachypnic with signs of obvious respiratory distress. So that doesn't really take very long to identify, less than 5 seconds. One of the things we don't really have a lot of time to kind of talk about the breathing patterns, but in this video, this cat actually has a dysynchronous pattern. So the chest and the abdomen are moving in opposite direction. I usually like to take about 5 seconds to look at my patient when they come in respiratory distress. and breathe the same way they're breathing, because it helps me, again, localize where the problem is. So again, I can really tell if it's upper airway because they have inspiratory airflow. But when the chest and the abdomen move in opposite direction, that's usually suggestive of pleural space disease. So this cat probably has pleural effusion, or a dog with pneumothorax will have that, where the chest and the abdomen moves in opposite direction. Again, lots of common reasons why we will see dogs and cats come in with breathing difficulty. So how do I assess that patient? I'm going to really do the same thing, but I'm also not going to forget about my point of care ultrasound, which again is, as a practitioner, as a veterinarian, I feel like this should be your best friend. So another disclaimer, other than being a terrible surgeon, I am also really bad at ultrasound. So I couldn't tell you if an animal had a foreign body, an intussusception, or whatever it is. I just use the ultrasound to identify fluid on emergency, and also to look in the chest to see if there's any pathology. So it's really easy to do. Obviously, in the interest of time, we're not going to be able to go through all the specifics, but one of the reasons I love it is, again, it's many practitioners have ultrasound in practice. It's really, you're not really exposing that pet or your staff to radiation therapy. And then because we're specifically talking about breathing, I can quickly identify those animals that have pleural effusion, pneumothorax, or potentially even a big left atrium, which would make me think this is probably cardiogenic. I can do that without taking them to radiology. I know some of you might be like, well, why? Why not just quickly take an X-ray? I can say personally for me, I have had at least one cat die. This is at the beginning of my career in 2005. Came in respiratory distress, went to get X-rays, got stressed out, and died on the radiology table. Especially cats, I think, can be susceptible, but also dogs when literally distressed. Sometimes they have something that's really fixable. This animal has pleural effusion, so I can identify with the ultrasound. I can remove the fluid, and the radiograph is actually more helpful to me after the thoracentesis. But because if there is a chest full of fluid, the X-ray is just going to tell me this pleural effusion, but I may not be able to see a mass possibly in the chest, or if the heart is big, because I have that summation effect from the fluid. So if I take the fluid off, the animal is a lot more stable, then I can go to radiology and get some X-rays and get diagnostic radiographs. This paper really quickly just, again, shows the importance of point of care ultrasound. This was a study primarily from Germany, but Belgium. They identified 130 dogs with pneumonia. So we don't typically think of pneumonia having pleural effusion, but roughly about 30% of those dogs actually had concurrent pleural effusion, which should be really easy to identify in point of care ultrasound. If it's a large volume, you can see it on X-rays too, but if it's a small volume, I find that sometimes that gets missed. So once we have identified, again, that animal with breathing difficulty, which is really easy to do, we're going to stabilize that dog and cat the same way as we would an animal that has an airway obstruction. So we're going to give oxygen. I will consider sedation. I find that sedation is not really as drastic or as dramatic with breathing difficulty as it is with an upper airway obstruction. Sometimes they respond to it, but sometimes, especially if that animal is like really compensating and struggling to breathe, sometimes when I sedate them, they relax and they just don't really want to compensate anymore. So I think if you're going to sedate an animal with breathing difficulty, you should be just ready to intubate them, just in case they get too relaxed and they're not really able to compensate for their hypoxemia. The other thing I consider, we already talked about pleural effusion or pneumothorax, would be thoracentesis. So this is going to be really important. Again, less probably urgent if the animal is stable, not cyanotic, not apopneic. Certainly you can take your time, but if that animal comes in and it's really distressed, I would say removing the effusion usually almost always provides immediate relaxation and stabilization for that animal. So you get the fluid out, the animal looks much better because now its lungs are inflated. I usually like to share roughly, it takes about 30 to 60 mils per kg of fluid or air in the chest to cause respiratory distress. I like to keep that number in mind because if you're doing a thoracentesis in a cat, that's an average of 4 kilograms, then you know that you want to get anywhere between 120 to about 300 mils, depending on the cat and the underlying disease process. If I only got 20 cc's of fluid out of that cat's chest, then it tells me one of two things. Either there's still more, you need to keep trying, and you need to get at least 100 to 120 mils to get the cat stable. And number two, there's something else. That amount of fluid is not enough to explain that animal's respiratory distress. There's something else going on in the lungs that is contributing to that animal's dyspnea. I would also consider furosemide. I will give it to every dog with a murmur. Dogs are almost always going to have a heart murmur with heart failure. Cats don't always have a murmur. So in a kitty cat, if the cat comes in and I see on my ultrasound that there's B lines, which is just infiltrates in the lungs, I will consider a dose of Lasix until I can get more diagnostics. And then same thing with bronchodilators. I would usually give albuterol, especially if the significant is a cat that might potentially have asthma. So it's a young to a middle-aged cat. That cat potentially has a history of travel or recently moved to the area. Or potentially the cat also has evidence of wheezes on my physical exam. I would give a dose of, usually I do albuterol. Terbutaline also works well as a bronchodilator. So in summary, breathing is also really easy to identify. The dogs and cats are going to look very similar to a dog or a cat with an upper airway obstruction. The only difference for the most part is they're not going to have that stridor, and that's how you know it's lower airway disease. All right, lastly, we'll talk about circulation, which is the third part of our triage exam. So again, we've identified airway obstruction and breathing difficulty in less than 10 to 15 seconds, really easy to tell. The part that takes a little bit of time is circulation, but again, you can have this done in 15 to 30 seconds. It is my favorite part to talk about because I love talking about pulse circulation. It's also called shock because many times I can see that animal respond really quickly to whatever therapeutic intervention I do to treat it. So I'm going to hold myself back and not go overboard today. But when we talk about poor circulation, we're talking about poor oxygen delivery. So for different reasons, this animal is just not getting enough oxygen to its organs. And the main reasons I like to think of to keep it simple will be because of a low blood volume or hypovolemia. So that animal that's been vomiting and having diarrhea, Pavlov puppy will be a good example. Another reason will be pump failure, so cardiogenic causes. That dog, that Dobie with DCM, may have plenty of blood or volume in its intravascular space, but because the heart isn't really working or beating well enough, it's not able to generate a good cardiac output and unable to get oxygen delivered to its end organs. The third would be maldistribution. So we see this in patients with like sepsis or pancreatitis, and in some instances, trauma. And what happens with this is your blood vessels in your artery, instead of being nice and constricted, those smooth muscles just get dilated, usually because of cytokines that are circulated in the bloodstream. So because your arteries cannot really constrict well enough, the body cannot generate a good blood pressure to move blood and oxygen to the end organs. And then lastly, obstruction like dogs with the GDV, where that big stomach just pushes in the vena cava. It affects venous return, which ultimately affects cardiac output. But it comes down to oxygen delivery. It's usually one of four reasons. For some, in some instances, you could have a combination. So you could have an animal who has hypervolemic shock, but also vasodilatory or maldistributed shock at the same time. But the reason this is life-threatening is we know that oxygen, in the absence of oxygen, the cells cannot make ATP. And ATP is really what keeps everything going. So in the absence of oxygen, your ATP production goes down. The animals start to make lactate, which is why we use lactate to evaluate oxygen delivery. And it ultimately leads to the death of the cell and the death of the animal if we don't reverse it quickly. So it's really easy to diagnose, even though it's probably going to take about 15 to 30 seconds. But the main things is dogs are going to be tachycardic. Cats, for whatever reason, they don't really shut down their parasympathetic tone in shock. So they're usually bradycardic. So a cat that comes in and the heart rate is like less than 160, that usually causes me to be very concerned because this cat is either in shock, or this cat is hyperkalemic, or this cat has some sort of cardiovascular abnormalities. We're going to see weak pulses because you don't have, again, enough volume in your blood vessels. I usually prefer to feel the distal pulses instead of the femoral pulses. Because it makes sense that when the heart pumps, the pulse quality is going to decrease as the blood goes down distally. So you're going to have better pulses in your femoral region or femoral artery compared to your dorsal pedal, which runs medially. So you could have a patient that's hypotensive, and that patient might have a palpable or maybe even a decent femoral pulse and have an absent distal pulse or dorsal pedal pulse. So ideally, if you cannot feel the dorsal pedal pulse that's absent, but you can feel a femoral pulse, that usually tells you that your systolic blood pressure is somewhere about 60. We start to feel the dorsal pedal pulse when the blood pressure is systolic pressure is about 90. So I prefer to reach for and try to feel the dorsal pedal pulse and make sure I can feel that. Pill mucous membranes, I have been certainly tricked by that a few times, where I thought it was because the animal was anemic, the puppy. And puppies have a low PCV. The puppy had a PCV of maybe 21, 22%. Give the puppy a blood transfusion. Puppy actually did worse because that puppy had like underlying cardiac disease and could actually not really contract well enough. And that's why the puppy was in shock, and that's why the puppy was pilled. So certainly poor oxygen delivery can cause pallor, prolonged capillary refill time, cold extremities, and if you are able to measure blood pressure, hypertension, and elevated lactate concentration. Cats tend to have this triad where you can see many of the signs in cats other than tachycardia, but we classically see cats in shock come in with not only bradycardia, but hypertension and hypothermia. That's almost very classic in kitty cats. All right, so the way we treat shock is we're going to start with placing an IV catheter. You want to place ideally the largest and the shortest catheter you have, because the longer the catheter is, the slower your fluids are going to move. And then the smaller it is, the slower the fluids move through the IV catheter. Unless you think that it's cardiogenic underlying cause of shock, unless you think it's cardiogenic shock, we're usually going to start with IV fluids. These dogs and cats don't come in telling us that, oh, I have maldistributive shock, so I need a vasopressor. Usually we're going to see how they respond to fluid therapy. So I usually start with an isotonic for steroids, and I will give 10 to 15 mils per kg over 15 minutes in a cat, but 20 to 25 mils per kg over 15 minutes in dogs. I think the big take home is we want to give this rapidly. So if you're trying to treat shock, the fluid should not be prescribed over 30 minutes or an hour. It's not really going to be fast enough. Your goal is you want to restore the volume in your vascular space and restore oxygen delivery. And you want to do that as quickly as possible. Those volumes are roughly about a quarter of our classic shock dose that we learned about in vet school, 60 to 90 mils per kg. So you're going to give the first dose, a bolus over about 15 minutes, and then reevaluate the patient. Is the heart rate better? Is the blood pressure better? Is the color better? If your answer is yes, then you can stop. If the answer is no, you can repeat that dose up to 3 times. And then just keeping in mind that some animals may require blood transfusions and vasopressors. We'll talk about this more next hour when we talk about GI disease. I wanted to make a quick note about shock index. So in some cases, again, in the interest of time, we didn't really talk about the different phases of shock. But dogs, especially in compensatory shock, they come in and they don't really have a lot of the classic signs. So this dog was just hit by a car. It's tachycardic. It might be because it's painful. Its heart rate's 200. It has decent dorsal pedal pulses. I'm not really sure about this dog's oxygen delivery. One way you can identify, we call it like cryptic shock, is to do the shock index, which is really easy to do. In human patients, it's been shown to be directly correlated with mortality. the higher the shock index, the more likely that person is to die. It just means the more likely this animal is in shock. So what you take is you take that animal's heart rate and you divide it by the systolic blood pressure. In dogs, anything greater than 0.9 is going to be very suggestive of shock. So again, I'm going to treat this animal more aggressively. So I'm going to drop what I'm doing and focus on this dog. I'm going to give it a fluid bolus and then recheck its parameters. In cats, that number is 1.6. So 0.9 in dogs, 1.6 in cats. And then it is, again, the heart rate divided by the systolic blood pressure. All right, so to finish up, we're just going to talk about some of our common presentations, which would be dogs and cats who are coming with a history of acute collapse. So lots of reasons. I have a slide that has like over 100 reasons why dogs and cats can come in with acute collapse to your practice, to me and you. So how do I treat and how do I assess that patient? We're always going to start with our ABCs, which we just went through that. So make sure the animal doesn't have an airway obstruction, breathing difficulty, or poor circulation. If they do, then you want to go ahead and treat them. The next thing I'm going to do is I'm going to put an ECG on that patient to see if that animal has an arrhythmia that's leading to the collapse, which we know that both tachyarrhythmias and bradyarrhythmias can cause collapse in dogs and cats. The most common tachyarrhythmias we see that cause collapse is usually ventricular tachycardia. We find that this is common in animals with heart disease, although there's lots of non-cardiac diseases that will cause ventricular tachycardia. Animals that come in with vomiting and diarrhea and shock. So anything that causes poor oxygen delivery to the heart can cause ventricular tachycardia, GDV, splenic masses. We're very familiar with all of these. How do I know when to treat? So I put an ECG lead on that patient. That animal is just having a ton of VPCs. My indication to treat will be if the rate is fast for that animal. So we usually think between 160 to 180. If it's a Great Dane, I'm certainly more likely to treat it when the heart rate's closer to 160 than 180. So I would treat if the rate is fast. I would treat if the animal has clinical signs. If there is evidence of RMTs or multifocal VPCs, the VPCs look different. So one's like white and bizarre, but more upright than the other. All it means is that those arrhythmias are coming from different foci in the ventricle, and it's more likely to be unstable. So I'm more likely to treat it. If I put the ECG lead on and it's all VPCs, but that animal has a heart rate of 100, it's an accelerated idioventricular rhythm that actually does not need to be treated. That's just something that I would keep an eye on. Once you decide that you're going to treat, treatment of choice is lidocaine, because lidocaine is short acting. I'm going to first of all make sure that this animal is going to respond to lidocaine. So I'm going to give it 2 mg per kg. What time do I go into? Thank you. You can tell me. Okay, perfect. All right, great. So we're going to do 2 mg per kg of lidocaine. I want to make sure this animal is going to respond to the lidocaine by giving a bolus. If there is a positive response, so if that rhythm converts, I know that my lidocaine is short-acting. It's only going to be good for about 10 to 15 minutes. So I need to continue that with a constant rate infusion. If the animal does not respond to the bolus, your options will be to give more. So you can repeat your lidocaine dose a couple times and see if there's response, or you can try something else. So usually we'll do procainamide, where you can also utilize amiodarone, which I'll talk about in the next slide. If that patient is responsive to IV antiarrhythmics, usually I will just start them on oral sotalol. It doesn't mean that they have to be on it long term. If it's a Dovey or DCM, it may need it long term. But if it is like an animal who's hit by a car and just has ventricular tachycardia, that animal may just need it for a couple of weeks. So they go home, they come back, get rechecked, and then that drug can be weaned off. I just wanted to kind of quickly share about amiodarone. So this is an antiarrhythmic that can actually be used to treat a bunch of different kinds of arrhythmias, including ventricular tachycardia. We haven't used it very much in veterinary medicine. It's like one of the top lines now in human medicine, or a drug of choice that's reached out for. We haven't used it very much in veterinary medicine because it used to be really expensive, also because of allergic reactions associated with the use of amiodarone. But there is a new form, which is Nexterone is the trade name. It just comes in a pre-mixed bag. And many studies have shown that this is, well, a couple of studies have shown that this can safely be used in dogs and cats, which is the same thing in my experience too. So if you have an arrhythmia like ventricular tachycardia that's unresponsive to lidocaine or procainamide, this would be a good option. It actually has a decent shelf life too, depending on how often you see cases like this in your practice. The next arrhythmia that's commonly will cause collapse or Brady arrhythmias, specifically high-grade second-degree AV block, third-degree AV block, like sinus syndrome. One of the ways you can tell is, does this animal just have a really strong vagal tone? Is that why the heart rate is so slow? Is you can do an atropine response test. So you can give the atropine. Some people will give half the dose IV, half sub-Q. And what you would expect to see will be an increase in the heart rate if this was all vagally mediated. If the animal was still profoundly bradycardic after giving atropine, then it probably most likely needs a pacemaker. I mean, you can try other things like theophylline. At least in my experience, I'm not a cardiologist, usually do not really find that usually helps very much. So if they come in collapsing because of a bradyarrhythmia that's unresponsive to atropine, they probably need a pacemaker. All right, so again, that collapsed dog, I'm going to assess my ABCs, put my ECG leads on, but I'm going to want to get blood from that patient. So I'm going to place an IV catheter and try to evaluate some blood work as quickly as possible. And usually what we do is we place a catheter, we get the blood from the catheter in almost, I mean, even from like 22 gauge catheters, we can get enough blood to do our lab work. Because I work in academia and everything takes forever, the blood work from my lab will probably take about 4 hours before I get it back on an average given day. I can quickly at least check the PCV, total solids, glucose, and lactate. Using a glucometer and a lactatometer, I can get those results usually in about 30 seconds or less. And the PCV, I can usually get back in about 2 to 5 minutes. So this is really easy to do. We can identify animals who are collapsing because of anemia, hypoglycemia. Again, things I can do something about really quickly while that patient is in front of me. The other thing I do would be to get a blood gas, which again, it's much faster than the chemistry in my institution, but if you can get a CBC chemistry and you can get that done really quickly, then go ahead and do that just so we can identify electrolyte abnormalities like abnormalities in calcium or sodium that can lead to collapse in dogs and cats. All right, the first thing I would do is I'm placing a catheter, we're getting blood, my technicians are helping with that, is I want to grab the ultrasound. So we already talked about this with breathing, but point of care ultrasound is so important in evaluating the collapsed patient. I was working in an urgent care clinic actually the other day, and this man brings his dog in that had collapsed, dog was terrible. We did all the steps, put the ECG leads on, put the ultrasound probe. I was quickly able to identify that this animal had pericardial effusion. I think one of the advantages of the point of care ultrasound, especially with pericardial effusion, is if it's an acute bleed and you take that animal to radiology, get chest x-rays, you may not see the classic change that we all learned in radiology. It's a big globoid heart. That usually takes a lot of effusion over time for the pericardial sac to stretch. So with an acute pericardial effusion, the heart may look completely normal, which again will be really easy to identify with your ultrasound, but then you can not only tell that it's pericardial effusion, you can move forward to stabilize that patient. So big highlights about the point of care ultrasound is it decreases the time for you to make a diagnosis when there's free fluid present in that animal. It's going to be much faster. Again, I take x-rays every day. It doesn't replace x-rays, but it's going to be much faster in that acute setting to make a diagnosis. In one study where they looked at all the patients that came in unstable from that practice, 3/4 of 75% of them had free fluid in the chest or the abdomen that they could identify, meaning that when you have that really sick patient, there's a good chance that there's probably fluid in the cavity that would give you an answer really quickly before having to spend a lot of money, but also it'll let you get to either stabilizing that patient or at least talking to the owners to give them an opportunity to make a decision on the pet. We talked about how the pet doesn't need to be moved. It's more sensitive, not only to pericardial effusion, but sometimes abdominal effusion. You have an animal with septic peritonitis, and there's just a scan amount of effusion. You may actually not even see decreased detail on abdominal radiographs, but you might be able to tell that there's a little bit of effusion on the point of care ultrasound. So just a big encouragement to consider it. Again, it's really great for other things, pancreatitis, foreign bodies, but when you have that unstable patient, I encourage those of you who don't to use the ultrasound more. The study just said it doesn't really matter what position you evaluate the abdomen in dogs and cats. Essentially, if they have fluid in the abdomen, you can do it in lateral recumbency, you can do it in standing, you're more likely you are going to be able to find the fluid. After the fluid is identified, what do? We want to remove the fluid. We can never ever tell what the effusion is just because we saw it on ultrasound. You might be suspicious. I don't want to be egregious, but if you had like an older golden retriever who came in and there's free fluid in the abdomen, there's probably a good chance that it's a hemoabdomen. But I have had cases where that animal actually had heart failure and the effusion was not blood, but it was secondary to this right-sided heart failure. So we always want to get the fluid and do an abdominocentesis or thoracocentesis / pericardiocentesis, depending on where the effusion is, because the ultrasound does not tell you. The options in the abdomen is it's either going to be blood or it's going to be septic peritonitis, bile, or urine. Pretty easy to get a sample with ultrasound guided synthesis if you have ultrasound. If you don't, I have the pleasure of being old enough to have practiced way before ultrasound. I definitely like practice with ultrasound better, but I have done a lot of blind, not only abdominal synthesis, but also pericardiocentesis and thoracocentesis. So if you don't have ultrasound, it is possible, but ultrasound does make the synthesis easier. One of the things that I do way less of is the 4-quadrant synthesis. So I used to do this all the time when we didn't really have ultrasound back in the Stone Age, but now I just use the ultrasound. But there are instances where the animal just has a scant amount of fluid. I've had cases where a radiologist could not even get the abdominal effusion because it wasn't very much. But then you're concerned about the patient because you're like really worried that this animal could be septic or something, so you really want to make a decision really quickly. I have found the 4-quadrant synthesis to be way more helpful in getting the fluid. And all you do is you identify the umbilicus, and then you just place your needle, cranial and caudal to the umbilicus in the dorsal and ventral aspect. I always use a 22-gauge needle regardless of the size of the animal, and I go all the way to the hub. And depending on how much fluid you have, sometimes you just need to put 1 or 2 needles and then your blood or whatever comes out. But in some instances, you have to put all 4. So I put all 4, like in this picture, and I usually just wait about 30 seconds, and then I aspirate back with a syringe, and if I don't get anything back, I pull the needles out. All right, so with hemorrhagic effusion, we absolutely always want to get a PCV because it may grossly look hemorrhagic, but then you spin it down and the PCV is only 2, so that's just really a serious gangrenous effusion that animal isn't bleeding. We always want to get a PCV. We always want to make sure that there are no clots identified in the syringe or whatever you pulled it in, because if there's a blood clot in it, it means you accidentally stopped something, usually the spleen, and that animal does not have a hemoabdomen until you can get a sample that's not clotting and prove that it's a hemoabdomen. Just a quick reminder that after trauma, hemoabdomens are not uncommon, and usually they do not need to go to surgery. It's usually the spleen or the liver bleeding. They usually self-bleeding. But with non-traumatic hemoabdomens, it's almost always because of the mass, and surgery is almost always indicated. The main exceptions is I have anaphylaxis. Do you all see a lot of anaphylaxis with hemoabdomens in Kansas? No, I think it could be maybe a little bit geographic, but we see it all the time at Florida, and we saw it some when I was at Tennessee. So dogs with hemoabdomen will come in, dogs with anaphylaxis will come in with a hemoabdomen. And then the other time you may see this to be with genocyte toxicity. So the animal had gotten into rat poison, which is obviously not uncommon. How do I know that this is anaphylaxis? Sometimes it can be challenging to tell, but my index of suspicion goes up if it's a young dog. Older dogs can also have anaphylaxis, so you can also have that 12-year-old golden retriever with a hemoabdomen, but it actually doesn't have a mass. It has anaphylaxis. So certainly looking at the signement helps me. If it's younger, then I'm going to be looking for other reasons. Although unfortunately, sometimes young dogs do also get neoplasia. Looking at my liver and spleen with my ultrasound to look for any obvious masses, but also looking for evidence of gallbladder wall edema. So I don't really know the incidence of this with anaphylaxis, meaning I don't know if 100% of dogs with anaphylaxis get this. I think it's probably lower than that, so not every dog with anaphylaxis would have it. But if you see evidence of gallbladder wall edema, so the gallbladder wall, instead of having just one distinct wall, it looks like a double halo, so there's two walls. That's going to be classic for anaphylaxis, although there are other reasons you can see it: right-sided heart failure, pericardial effusion. But the animal that has a hemoabdomen that also has gallbladder wall edema, especially if it's a young animal, I'm going to be treating that animal for anaphylaxis until proven otherwise. All right, we're still talking about free fluid in the abdomen, so that was with blood. Just wanted to kind of share a quick reminder with bowel peritonitis, 40% of dogs are going to have a normal serum bilirubin. So if you do your blood work and your bilirubin is normal, it doesn't rule out a bowel peritonitis. One of the helpful ways you can make your diagnosis is cytology to look for bilirubin crystals. But also you can do paired bilirubin levels where you get the fluid out, you run it through your chemistry machine, as long as it's not like clots in the fluid. And if the bilirubin is higher than the patient's bilirubin, it's going to be very suggestive of bowel peritonitis. But this I have also found to be unrewarded in some cases where the animal's bilirubin in the fluid was the exact same as the bilirubin in the bloodstream, but surgery proved that the animal actually had bowel peritonitis. All right, so that's our summary for acute collapse, ABCs, ECG. We're going to do some blood work, use a point of care ultrasound, and then move on to perform other diagnostics. Really quickly, we will talk about animals who are hit by a car, vehicular accident. That's obviously really important. Those animals can come in completely stable. I was talking to somebody on the radio the other day, and he was like, well, obviously, if a dog and a cat is hit by a car, then they're going to die, and you would think so, but as we all know, it doesn't always happen. It's miraculous. Actually, my dog, I got him because he was a good time hit by a car, and he was like 5 pounds at that time, and he is doing great. So they can come in and they can come in, they can be really lucky and be stable, but sometimes they come in with life-threatening clinical signs. So how do we approach this patient? It's going to be the same thing. We're going to go through our ABCs to look for things like hemoabdomen, pneumothorax, diaphragmatic hernia. We're going to identify any breathing difficulties and circulatory abnormalities. Generally, we're hit by cars. We don't see a lot of airway obstruction, although sometimes in trauma, they can have a hematoma obstructing the airway. We're going to place an IV catheter as soon as reasonably possible. And then we're going to assess the PCV total solids, as well as glucose lactate in your blood work. But the big take home with this is with acute blood loss, your total protein is going to be way more important than your PCV. Because in some instances, it can take many hours for the PCV to equilibrate. So I am going to be a lot more concerned about a dog that has a hematocrit of 45 and a total solids of 4. That's going to scream hemorrhage to me if that animal has a history of trauma. And it doesn't necessarily have to be just trauma. Animals with a hemoabdomen, they come in and the PCV is 47 and the total solids is 3. That's going to be very suggestive of hemorrhage, as opposed to a PCV of 39 and 7.0. When the total solids is normal, it's less likely going to be, again, acute blood loss. For chronic blood loss, I would expect the PCV to drop, so the PCV is going to be helpful. But acutely, we want to make sure we pay attention to the total solids. We already kind of talked about lactate. It just means the animal has poor perfusion, so we want to assess the heart rate, pulse quality, blood pressure, and treat that animal with fluids or blood transfusion if needed. All right, analgesia. We know that this has a direct correlation with morbidity and mortality. The evidence is actually not as, there's not as robust evidence in veterinary patients, but there is a lot of evidence in human patients. And I think that's something we're all really good about, but certainly something to keep in mind because sometimes people worry this animal came in and was hit by a car. It's very obtunded. It's not very responsive. I'm really worried about giving it pain medications. And I think what you find sometimes is when you treat the pain, the animal actually looks better. It opens its mouth, it feels eyes, it feels more comfortable because you've given it analgesics. So with trauma, we're going to concentrate on giving opioids. They're really going to be our best drugs of choice because they cause very minimal hemodynamic instability. I think the reason a lot of us are worried is because, well, this animal probably has a low blood pressure. I don't really want to make it worse, but it's really, really hard to make it worse with opioids at an appropriate dose. So that's usually what we're going to choose. The other question I get will be vomiting. And the summary of the slide is essentially when we give opioids, they can cause emesis by acting on the CRTZ in the brain. But when the concentration of the opioid is high enough, it actually affects the vomiting center and it acts as an antiemetic in the vomiting center. And the best way we can get the opioids to get to the vomiting center really fast is to give it IV. So if you give it IV, you have a high enough concentration in the bloodstream that actually suppresses emesis in the vomiting center. So you're not going to be seeing vomiting unless you give it super slow IV in general. You're not going to be seeing vomiting, but if you give it IM or sub-Q, that animal is more likely to vomit. The other, I think the last take home about opioids is kind of keeping in mind that our pure mu agonists are going to be the best for animals with moderate to severe pain. Buprenorphine is a partial agonist of the mu receptor. While it has a ceiling effect, which is great, meaning that even if you overdose it, it kind of has a max effect on that patient in terms of analgesia and also adverse effects. Pretty safe. But it's really just going to be good for mild to moderate pain. So if you have an animal with a broken leg, if you had a choice, I would pick a pure mu agonist. But if that animal has maybe some abdominal pain, maybe pancreatitis, buprenorphine will be a better choice. And we'll kind of talk about opioids with GI disease after lunch. This has nothing to do with the first 5 minutes of an animal coming in, but I'm really excited because I think we've had very limited options to go home analgesia for especially patients who are like critically ill or injured, gabapentin, which we know that doesn't really do very much in dogs. But the study came out recently, and this is one of, I think it was 2 or 3, where you can give buprenorphine either intranasally or transmucosally in dogs, so you can send it home. And this one, they used Synbudol, which we historically think about using in cats, but they used Synbudol in dogs, and it worked. At least they got high enough concentrations in the bloodstream to reasonably say that this is a good option for analgesia. The dose they used was 0.03 mg per kg. All right, so we've done giving pain meds to this animal that's hit by a car. The next would be, we already talked about ultrasound. I'm not going to belabor that very much. And then just moving on to say once that patient is stable, you want to do your full physical exam. Sometimes with animals with trauma, you have to examine them not only multiple times, but you may not be able to get the full exam done in one sitting because that animal is not ambulatory, maybe not very comfortable. You might give it some time and its pain meds before you go back to reevaluate the patient. So reevaluation is important. Also, a big highlight for thoracic radiographs, I recommend it in all patients who have been hit by a car, even if they don't have respiratory signs. And the reason I do that is diaphragmatic hernias, sometimes they don't have clinical signs, so especially in cats, like they look fine, and then, 2 months later or a year later, they come in respiratory distress because the hernia has shifted. So I always recommend it if the owners can afford it. I recommend abdominal rads or pelvic rads, depending on what clinical signs the animal has. If it obviously has a broken leg, then I might get pelvic rads or abdominal rads. Quick summary about steroids, no benefits that they help do anything with trauma. So the only thing they do is they take us away from giving the patient what it really needs, which is like pain meds and oxygen and getting the patient stable, but it doesn't really make a difference in outcomes for dogs and cats. All right, we're almost done. Next hour, I'm going to talk about gastrointestinal emergencies, but I did not have time to talk about GDVs, so I put it in here. pretty straightforward. I think pretty much all of us in the room, we can identify a dog with a GDV when the client calls. It's a large breed dog, it's deep chested, it's retching, trying to vomit, nothing's coming out. Whether it's a GDV, we have them come in, the animal comes in, the animal's abdomen is distended. We know it's a GDV. So the last place that animal needs to be is radiology. We still want to get an X-ray to confirm it, but if the stomach is this huge, in some cases, not in all cases, it again pushes on the vena cava. It reduces how much blood is going back into the heart. This animal may be in shock. They're not always in shock, but I think many times they are. So the first thing we should do is still stabilize the patient. So go through all the steps we talked about with that ABC, place an IV catheter, give them fluid. After that animal has been stabilized, decompressed, give them pain meds, then we can go to radiology to get a diagnosis. Because again, there's a chance, especially if the patient is really unstable, that dog could die in radiology while we're trying to get an X-ray, even though it's just a quick right lateral. I think in all things, it's just going to be the same for us. If we're going to the ER and we're unstable, regardless of what's wrong, we are going to be stabilized first. So we're going to go through our ABCs. We're going to, this is just a cool thing I've been using of late that I wanted to share. It's called the LifeFlow. This is a great way for large breed dogs to give them large volumes. Going back to how I talked about how we wanted to give fluid bolus of 15 minutes. So if I had a Dobie that was about 40 kilograms and I wanted to give it 800 mils, you can't really give that over 15 minutes with a pump. You can use a pressure bag, but you can use this LifeFlow. It's essentially like a gun, and you just attach it to your fluid, and then you just pump it in, and you can actually get a whole liter in about a minute or two. So really cool, really easy to utilize. We're going to give pain meds to the patient with GDV. But we also want to stabilize them by getting rid of that air in the stomach and getting rid of the distended stomach. And my treatment of choice is trocarization. You can certainly pass an orogastric tube. I find that to be more challenging when they're awake, easier when they're under anesthesia before surgery. But in this picture, we just have like a 14-gauge catheter. I just fill for the tympani. Along the animal's abdominal body wall, I shave, and then I just insert the catheter in. Sometimes I do two if the stomach is distended, and you can usually hear the air come out, and the abdomen becomes softer and smaller, and then I go to radiology once that patient is comfortable. I think this is the last one. Filling urethral obstruction. 12:20. Yep, 5 minutes. All right, so this is a true emergency. And it's a true emergency because of a life-threatening hyperkalemia. So when you look at studies in cats where those cats have died from urethral obstruction, it's really rare that the cat dies from a ruptured bladder, which certainly can happen and does happen. Usually the hyperkalemia is going to kill them way before the bladder gets big enough to rupture. So the big take home from this segment is knowing or realizing that, and this has been well established in dogs, cats, and people, that the heart rate does not predict hyperkalemia. So the cat comes in, and you expect that if the potassium is high, the cat will be bradycardic. And it happens sometimes, but in some instances, I've seen cats with a potassium of 10 or 11, where the heart rate is still 200 or 220. So having a normal heart rate does not rule out hyperkalemia. Same thing with your ECG, which also there's been 2 studies in animals looking at this, where the ECG may be completely normal with the high potassium. When I went to vet school, I was given this chart, which essentially kind of predicts what the ECG would be based on the potassium concentration. We know that this is not, dogs and cats and people do not read the book. And I think the really scary part is you could actually go from a normal sinus rhythm where there's no ECG changes to ventricular fibrillation, which just means the cat is dead because the heart's not beating, and not have any abnormal ECG changes in the middle of it. So ECG again doesn't really predict hyperkalemia. And I emphasize this to just say that when that patient comes in and needs pain meds, we need to check its blood pressure. It's really rare that this cat's in shock. But we need to evaluate the potassium before sedating it because that cat's more likely going to have complications under anesthesia with the high potassium than if the potassium was treated. So regardless of what your ECG says or what the heart rate says, we should still measure potassium concentration. When should we treat hyperkalemia in cats or dogs, depending on what the situation is in a dog? We don't really have any clear consensus in veterinary medicine. In people, 6.5 is the magic number when they start to get concerned. For me, I would do it if the animal has clinical signs, so the cat is bradycardic, which you can sometimes see with the potassium that's fairly elevated. Cat comes in with a potassium of 6.4. That's not very high, but the cat has a habit of 120. I'm going to be more likely to treat. I'm also going to be more likely to treat if there's ECG signs present, regardless of what the potassium concentration is. So how do I treat hyperkalemia? I really like regular insulin. You want to give insulin that's quick acting, but also short acting. I don't want to give this cat NPH or something that's going to be in circulation for 12 to 24 hours in this non-diabetic cat. So I usually would do regular insulin. It usually starts working within about 15 minutes. And for the average cat, I just do 1 unit. I give it IV so it works fast. Because insulin is going to cause hypoglycemia, we're always going to follow it with dextrose. I would give a dextrose bolus, so 3 mils for the average cat. For my regular insulin that I just gave, can actually kind of hang out for 4 to 6 hours. So I just always put the cats on a dextrose CRI. You could do that, just put them on 2.5% dextrose. I do it for about 4 to 6 hours and then kind of wean them off based on what their glucose is doing. You could also just give a bolus and recheck the glucose, but I just prefer not to like poke the cat instead of checking the glucose every couple of hours. I just put them on a dextrose CRI. The advantage of a dextrose too is dextrose by itself could bring their serum potassium down. The goal is when you give dextrose, the cat becomes hyperglycemic, and then you're relying on the pancreas to make more insulin, so secrete more insulin, which is going to bring the potassium down. So that would also be reasonable, except again, you're hoping that the pancreas actually will produce a high enough concentration of insulin to bring the potassium down. I use a lot of albuterol. I just do 1 to 2 puffs per cat. You can also use terbutaline. Calcium gluconate, as we remember, does nothing for the hyperkalemia. It really just helps protect the heart, so you're less likely to see those arrhythmias when you utilize calcium gluconate. And then sodium bicarbonate is also an option if you did not have any of this available. I stay away from sodium bicarbonate as much as possible. Not only because it takes the longest to work, 45 minutes to an hour before you start to see a reduction in your potassium concentration, but it's also more likely to have adverse effects. You're making them hyponatremic. They can have a paradoxical cerebral acidosis. So I personally don't use it because I have access to other things, but it's a reasonable option if you had a cat that was really hypokalemic. But I would give that cat a lot of dextrose and try to see if I could bring the potassium down. All right, I think I finished right on time. I'm sorry that I kind of ran through some of those. I will we'll take questions with the session at 4 this afternoon.